Hi guys, we're going to talk about fluid and electrolytes. And why is this important? Why is it important that we review our lab results? The night shift draws the labs on our patients around 4 a.m. usually, and you get the report around 7. So you need to review your labs in order to start your day. So why is that important aspect of our job? What is it telling us? It's telling us about our electrolytes and that balance. It tells us the general status of our patients, and so we're going to focus on fluid and electrolytes today, which is just a fundamental skill that you will use every time you work with your patients. Fluid surrounds all of the cells in our body. This fluid in our body is called serum. Why is that important, and what does it do? So let's chat about it. So functions of water in the body is important. In our body, we don't call it fluids, we call it serum. So this slide is going to tell us what the liquid portion of our blood actually does. And if we don't have enough, then it alters our homeostasis. So transports nutrients to cells and wastes from the cells. This is a major function of water in the body. It also transports hormones, enzymes, blood platelets, and red and white blood cells. So what do our red blood cells carry? Oxygenation. And all of these are transported around the body where it needs to be. So we have to think, what if I don't have enough blood serum or we are dehydrated? What can happen to us? Honestly, we could die, right? Absolutely. We call that hypovolemia, which leads to shock because we aren't getting the nutrients, the red blood cells, the white blood cells, to those areas of the body that actually need it. It also facilitates cellular metabolism and proper cellular chemical functioning. Nothing works if there isn't enough fluids. It acts as a solvent for electrolytes and non-electrolytes. It helps maintain normal body temperature. It facilitates digestion and promotes elimination. It also acts as a tissue lubricant. So water is the most important nutrient in our life. Although a human can live several days without food, humans can only sustain a few days without water. It's just that important. So let's talk about where that water is located. There are two compartments of fluid within the body, intracellular fluid and extracellular fluid. When we think about our intracellular fluid, that's found inside the cells, about 70% of the fluid in our body. Extracellular fluid is found outside the cells, and it's about 30% of the fluid. This is divided into two major divisions. The extracellular is then divided into two major divisions, and we can think about blood or vascular system. Interstitial fluids found between the cells, but outside the blood vessels. That's those lymphatic channels. So if you have a patient with lots of fluid found between the cells or interstitial, like in their ankles, we would call that edema. What of your body weight is water? 50 to 60%. So a healthy young adult has more muscle mass. Does muscle have more or less water than adipose tissue? It has more. That is really important because young healthy adults and you have lots of muscle tissue. So your risk for getting out of balance is very low. But what if you are an older woman, and I say woman because we unfortunately have more adipose tissue, and I get dehydrated? Do I have more side effects? Yes, I do, because I have more adipose tissue and less stored up, less muscle mass, which puts me at higher risk for dehydration. An infant has considerably more body fluid and extracellular fluid than an adult. So they are more prone to fluid volume deficits. Females and obese patients have less body fluid. This is why men can work out and lose 5 pounds in one day. because they have more body fluid with that muscle mass. So here's just another picture showing that total body fluid of a normal adult being 50 to 60% of our body weight. So why do we need to know the difference in isotonic, hypertonic, hypotonic fluids? Isotonic means that we have the same concentration. So you can see the normal cell in that top left corner. If I'm going to give an isotonic fluid, what does that mean? That means it has the same concentration and the same amount of electrolytes inside the cell as outside the cell. So what happens? Nothing happens. The shift of fluids in and out is easy, and this creates homeostasis. If I'm thinking about a hypotonic solution, this means lesser concentration of particles than plasma. So now I want to give a hypotonic. Is it more or less concentrated? And it is less concentrated. The electrolytes aren't going to shift. The fluid will shift in. So my question is that a problem? And it can be. So think about your marathon runner that didn't prepare well for the marathon. They thought it would just be fun. You get 5 miles in and you start getting dehydrated, and it gets worse and it gets worse, meaning your cells have shrunk, and this is the fluid you would give to pull fluid in the cells. So, but too much of this could rupture that cell. So that is your hypotonic solution. When we think about hypertonic, then this is a greater concentration of particles than the plasma. So you'll see these fluids given much more often. If we give hypertonic solution, that means we have more electrolytes. So now I have more electrolytes outside of the cell than inside. The fluids shift out in order to maintain homeostasis. Is that a problem? It can be a problem. We may be giving them a hypertonic solution because they've had too much fluid and we give it to shrink down the cell. But what if we give too much? Then it's going to severely damage that cell. So these solutions can be kind of scary, so we don't want to give them for more than about an hour because of the risk of damaging those cells. So when you're giving fluids, you should always think, is this hypotonic, is it isotonic, or is it hypertonic? And that's going to tell you what's going to happen once you start administering it. So let's get familiar with what type of solutions are each. Normal saline is isotonic, where half normal saline would be hypotonic. It should make sense, right? It's half of the concentration, meaning less electrolytes. LR, or lactated ringers, is our most closely related to our body fluid. So when we think about those isotonic fluids, it's staying in that intravascular space. So dehydration, fluid loss, diarrhea, vomiting, electrolyte loss, burns, labor and delivery, we're going to give those isotonic fluids. Hypertonic is going to pull fluid into the extracellular spaces. So things like diabetes, ketoacidosis, or DKA, shock, blood sugar levels, we're going to want to utilize those hypertonic fluids. And you can see those listed there, 10% dextrose or D10, we can do D5W, and then we can also do D5 in normal saline. If our patient is NPO or taking nothing by mouth for surgery, we may give them some dextrose to maintain those blood sugars. Then we can look at hypotonic fluids, remembering these are going to shift fluids from the extracellular compartments into the cells because the solvent is more dilute. So GI loss, fluid replacements are good disease processes where we're going to give a hypotonic solution. So this is just another slide to differentiate between isotonic. You can see at the top, right, it's level, it's equal. Hypotonic, you can see, and raises it up, and then hypertonic has more so that you can see that teeter-totter goes down there. So what are some other things fluids do for us? Fluid is not just about intake, it can also be about absorption. And are we absorbing it correctly and distributing it and eliminating it correctly? So as a general rule, how much fluid should I take in and put out? So we've talked about that previously. 2.5 to 3 liters is how much we're going to take in, and that should be what comes out. So what are some examples of patients that may not have that much in or out? So I can consider kidney diseases, cardiac diseases, right? We don't want to put that much in because if we have kidney disease, it's not going to come out. If we have cardiac disease, it's going to be overload. So these patients can't take that much in, so they may not distribute it well, and the extra fluid may go into the interstitial spaces, right? Those are those spaces between. So the lungs, the abdomen, the feet. So those are things that we have to consider. So how do we take fluid in? We can ingest those liquids, right? Hopefully water being that main one that we are ingesting. We can have it taken in by food. Some of our liquids come from foods, fruits, veggies, they have lots of liquids in there. But how do we lose it? We can lose it through urine, through feces, through perspiration, through our skin. Those are, and also some insensible water loss. Those are those losses that aren't able to be recorded. Breathing, you can't calculate that fluid loss. But if you have perspiration, insensible fluid losses, you can calculate almost about 300 to 500 mils of fluid loss by just breathing in a day. So what patient population would lose more? Tachypnic or febrile patients, right? If we're thinking about fast breathing and temperature, right? You could lose 800 to 1,000 mils. So those would be patients that we would be concerned about not getting in enough fluids. So what are some assessments we can think about when we're considering our fluid status? We know that it's essentially the same amount as we take in that should be coming out. We need to check to make sure that's true. So what can we do if we're keeping up with this intake and with this output over 24 hours and they're not equaled? We need to figure out why. So we can do a daily weight. Usually that's a very good indicator of fluid status. A normal person can only gain about ½ of a pound by overeating. So if more than that, then it must be retained fluid. Each kilo of weight gained or loss is equal to 1 liter of fluid retained or loss. And then we want to make sure that we're being accurate when we weigh our patient. So remind me of the process of obtaining that daily weight. Remember, same time, same scale, same bed when it's zeroed out. What if they have a weight gain of 1 kilo? We might want to reweigh them, make sure that's accurate. Maybe we're going to restrict fluids. We're going to call the provider, and we may need to give a diuretic at that point. So let's talk about fluid imbalances, and we're going to start with a deficit. Deficit meaning too little fluid. So I want you to take a minute, try to define each of these on your own, pause the video, and then let's see what we can come up with. So the first one is blank is caused by a deficiency in the amount of water and electrolytes in extracellular fluid with near normal water electrolyte portions. So that part is important. I haven't lost sodium or potassium, but I'm losing everything else at the same ratio. So that would be hypovolemia. And this often happens when you're losing actual blood. So the next one is what is decreased volume of water and electrolyte change? So there is a change, but their ratios are different. They may be losing one electrolyte faster than the other. This is dehydration. And then the last one is distributional shift of body fluids into the transcellular compartment, such as pleural, peritoneal, pericardial, joint cavities, bowel, excessive, right, into those interstitial spaces. So this one's actually third spacing, remembering that's that third space or that interstitial space. So let's go in the opposite direction now, and I'm going to give you a minute to look at these. So when we're talking about excessive retention of water and sodium in the extracellular fluid, that would be hypervolemia. The second one is above normal amounts of water in extracellular spaces. That is your overhydration. And then what if we have excessive extracellular fluid accumulating in those tissue spaces, right, in those interstitial spaces? And that would be your edema. Okay, so let's talk about clinical manifestations of dehydration. So we've talked about dehydration is probably an imbalance as far as a deficit. So we need to figure out what are those manifestations, what are those signs and symptoms of dehydration, and how do we know if our patients are dehydrated? So our patient shows up randomly with assortment of symptoms, and it could be because of dehydration, but we need to figure out what are those symptoms. So here's my first question for you. What is the impact on pulses? So the impact on pulses is that it's going to increase. Why does it increase when I am dehydrated, right? Common sense would tell me, oh, that should decrease. Well, there's a compensatory mechanism, so it's compensating. So when your volume decreases because you're dehydrated, there is less oxygen to those tissues. If the brain has less oxygen, it tells the heart to increase the heart rate. So the worse the dehydration, the faster the heart rate. What happens to your blood pressure? It actually goes down, right? Compensatory mechanism makes it goes down. So what is a blood pressure? Remember way back when we were talking about this? It's the pressure against the blood vessels themselves. Is there much volume to put pressure against those vessels? No, right? Because we're dehydrated. So even when your heart rate goes up, it is still not pumping more volume. The blood pressure is going to go down. Postural positioning also becomes a problem. So when they go from sitting to standing, they can become dizzy or even pass out. What happens to our skin color? They become pale, maybe cyanotic or that blue color, right? Because there's not enough oxygen in the blood because there's not enough blood because we're dehydrated. What happens to our skin turgor? The mobility of the skin because of the fluid in the skin is the fluid in the skin, right? So if you're dehydrated, it's going to stay tented. And then the quality of the pulses. So centrally versus peripherally. If I check a radial pulse and I count 60, and then I check a carotid pulse, what would I expect if my patient is dehydrated? They won't be even, right? Why? I have to save my vital organs, and it's going to shift that blood from the extremities into those vital organs. So you will feel the peripheral pulse, then it may be weak, but you go to the central pulse and it is fine. Then you know the body has shifted those fluids to save the organs. So all of these symptoms may vary just depending on the severity of the dehydration. All right, let's talk about respiratory changes. So that was our peripheral changes. These are now our respiratory changes. So increased respiratory rate because the lungs are trying to compensate, right? They become tachypnic. If my brain recognizes that I'm not getting much oxygen and I'm hypoxic, it's going to increase our respiratory rate. We also need to look at the are they good quality breaths, right? No, typically they're very shallow breathing. Is their work of breathing increased? Yes. How do we know that, right? We're using those accessory muscles. We can see their ribs when they breathe. The nares may be flaring. We may be breathing fast, shallow, and ineffective. So what happens to our pulse ox? It goes down. When we think about neurological changes, what happens in the brain? There's definitely changes in our level of consciousness. We may start with a little confusion, and it's going to become more severe as the dehydration gets worse. So we can ask very specific questions. Person, place, time, situation. They may be little things. They may remember being in the ER, but they may not be able to remember getting to the floor. So very subtle, very slow. So just being aware that you're going to have some neurological changes. So what are some of the renal changes? What is happening to our kidneys when we're dehydrated? We want to look at the trends in their urine output. What happens to your urine output? When you don't have enough circulating volume, it's going to shut down the urinary output and start reabsorbing it, meaning your urine output is going to be decreased. As your urine output decreases, what happens to the quality of the urine you do put out? What does the urine look like? It's going to be very concentrated, dark color. Is that a good thing? No, because it can actually do permanent damage to our kidneys. So this slide just shows more signs and symptoms of that fluid volume deficit. What about the labs when you're dehydrated? So let's look at some of these electrolytes. What's going to happen to sodium? What's happening with your sodium level? It usually does increase. If I'm losing water, then I'm concentrating sodium. The electrolytes are more concentrated. When we're thinking about renal function, again, what's happening to my kidneys when we're thinking about our labs? We're going to look at the BUN and the creatinine. BUN typically will rise first, and then the creatinine will elevate as the dehydration gets worse and the kidneys become more damaged. Hemoglobin and hematocrit are going to also increase due to the concentration of the body. So why does it go up? It's hemoconcentrated because of the low volume. So when we give fluids and we draw labs, the next day the hemoglobin will significantly go down because we've rediluted our hemoglobin. And then serum osmolarity increases the concentration. So this is going to go up. We don't have much circulating blood because of our fluid loss. So how are we going to manage these deficits? We've kind of talked about each of these, right? I's and O's, drawing some labs, looking at our patient as a whole, all right? Checking their weight, doing all of those things. And that's how we're going to manage our fluid volume deficit. So let's flip to the other side. Now we have too much fluid, right? We're going to think about clinical manifestations of fluid overload. What is my patient going to look like? Fluid overload doesn't just happen. If I decided today I was going to drink 6 liters of water, could my body handle it? Yeah, I could probably tolerate it. But who's not going to be able to tolerate it? Our heart patients, our heart failure, kidney failure patients, if they have endocrine issues, something is usually wrong. So basic healthy people don't go into fluid overload. So let's start with the heart. If your patient is in fluid overload, meaning there's too much fluid on board, what happens to the heart? What happens to the pulse and the quality of our pulses? They become tachycardic with those very bounding pulses, right? We have too much fluid, so our pulses are very bounding. We talked about blood pressure, right? That's that pressure against those veins. Is there a lot of pressure against the veins? Yeah, we've got lots of blood rushing through because we're on overload. So we're going to see an increase in our blood pressure. What about the soft tissues? All of the edema is happening. We call that hydrostatic pressure. When we have so much fluid in the intervascular space that we can't handle it, it starts being forced through the vessels into the surrounding tissue. So where are you going to see this shift? You'll see edema in their hands, their feet, their face, their eyes, their abdomen, also called ascites, lungs, neck veins. If you have them turn their head, that neck vein is going to really bulge out on our overload patients. What are some of the respiratory changes? What's happening in the lungs when we're talking about fluid overload? Is breathing really effective? So when I listen to the lungs, what do I hear? Crackles, right? They're nice and wet. Are their breaths nice and deep? Absolutely not. They're very, very shallow. So we're going to hear wet, shallow, crackly breaths. What about the brain? Alterations in level of consciousness, we're going to see confusion. The worse the overload, the more confused our patients are. And this is very similar to dehydration. So in all reality, whether they're dehydrated or they're fluid overload, you're going to have some type of confusion happening. But you also may see some other symptoms. So some neuromuscular functions. What do you think their head feels like when they have too much fluid, right? They may complain of headaches because there's so much pressure. Headaches to the point that it could affect their vision. We also need to think about their muscles. This can cause weakness due to those electrolytes that have shifted. We talked about the fluid moving from the vascular space into the interstitial space, right? Hands, feet, face, mouth, abdomen. But it also can accumulate in places like the liver and the spleen. So hepatomegaly, splenomegaly, remembering this isn't a permanent damage or permanent change unless it lasts for a really long period of time. So you can see on this slide, this is just a recap of those symptoms that we can see with overload. As far as lab findings with our overload, what happens to the electrolytes? Remember, they're going to be so diluted, they're going to decrease. When we think about renal function, that's going to increase because the kidneys are not getting what they need. So the BUN and the creatinine are going to rise. As far as hemoglobin and hematocrit, that's going to go down, right? It's very diluted. And then our osmolarity is also going to decrease because we have too much fluid on board. So we looked at the type of fluids, we've looked at overhydration, we've looked at dehydration. Now let's look at these very specific electrolytes. There are several electrolytes and it can be very extensive. We're going to just focus on two of them, sodium and potassium. You will add more when you get into your HR clinical or class. When we think about electrolytes, we can think about them as cations or anions. Cations being those positive charge electrolytes. Sodium, potassium, calcium, magnesium. Anions being the negative charge electrolytes. So chloride, bicarb, phosphate. So let's look at the basics of what our electrolytes do. So you can fill in these blanks if you know what your electrolytes are doing for you. So what is the major electrolyte in our extracellular fluid? It's essential for acid-base balance, irritability, and conduction of nerve and muscle tissues. So when we talk about a deficiency in this, it's all about the nerves and the muscles. So what electrolyte is this? It is sodium. So sodium is all about the muscle tissue and conduction because it lies in the extracellular fluid. It's a bigger number. So that normal range for sodium is 135 to 145. So let's move on. This cell metabolism, transmission of nerve impulses, if outside of the normal range, then major concern is cardiac. So the number one concern is our heart. If you get too much of this one, you will die. So what electrolytes is this one? And that is your potassium. Potassium is a big deal. If it is even the slightest out of range, we get worked up. It is an intracellular electrolyte, meaning it's a small number. So the normal ranges for potassium is 3.8 to 5. So 4.5 would be a really great number. A slight change in this number affects your heart. The next one is the nerve impulse, blood clotting, muscle contractions, bone and teeth formation. So what is this one? And that is calcium. The next one is that it's mostly found in bones, vital actions involving enzymes. And what is this one? That is your magnesium. And the last one is bicarbonate. It's the body's primary buffer system. So for this class, we're just going to focus on sodium and potassium. Common imbalances we may see. You'll need to know this terminology. Hypo meaning low, hyper meaning high. Hyponatremia means low sodium. Hypokalemia, low potassium. Hypocalcemia, hypomagnesemia, hypophosphatemia are all low. Versus our hypers, which are our highs. So here's the normal values for each of those. Remembering we're really just going to focus on sodium and potassium for this class. So there are a lot of commonly used medications that also cause fluid, electrolyte, and acid-base imbalances. And these should look familiar to you from your pharmacology class. ACE inhibitors are cardiac meds, and they are common in that population over 65. Corticosteroids, are they commonly given? Yeah, they really are. They'll use those for any type of inflammation. When we think about diuretics, we have to remember that these are also commonly used, especially in our older population, and we have to really watch those potassium levels. Laxatives, NSAIDs, so for example, ibuprofen, long-term can cause some electrolyte issues. Penicillins, high-dose hypokalemia, penicillin G, right? All of those can lead to hyperkalemia or that high potassium. So if your patient is on any of these, it just needs to be a red flag to be aware that an imbalance could occur. So this slide is going to talk about just some labs that we need to look at if we are suspecting an imbalance. When we look at electrolytes, that's going to will tell us those values, right? What kind of labs do you want to see on a CBC? We're going to look at white blood cells, red blood cells, platelets, hemoglobin, hematocrits. The CBC will tell me what else could be happening or what might be contributing to my imbalance. When we look at the serum electrolytes, BUN, creatinine levels, that's checking on our kidneys and how well they are working. We'll look at urine pH and specific gravity, and then we'll talk about arterial blood gases, our ABGs. And what are ABGs? This really talks about the pH in your blood, and we're going to spend a great deal tomorrow looking at different ABGs. So nursing interventions are going to vary just depending on the imbalance that the patient has. You really focus on these next module in HR, so I'm going to move past a lot of these. As far as physical assessment, we'll think about daily weights and our I's and O's. We've already talked about these things. Just know how much of an impact that this can have on them. Rapid weight gain can tell us a lot about kidney function. Kidney function has a lot to do with our electrolytes. Heart failure means they're going to retain weight, which is going to affect those electrolytes. So I want you to help me figure out the causes of hyponatremia. So remind me again what hyponatremia means. That means we have a low sodium. So what inside your bowel could cause low sodium? Diarrhea, vomiting. We learned about a procedure that contributes to hyponatremia, right? We talked about ostomies, specifically a very high ostomy like an ileostomy. What about NG tube to suction? It is almost like vomiting. We're losing all of that. What about enemas? Why would putting an enema in cause low sodium? What type of enema would cause this shift or this imbalance. And if you can think way back in concepts of 1, we talked about a tap water enema. Could cause us to become hyponatremic or cause that shift. What about renal? What could cause a loss of sodium through our kidneys? As far as medication classes, our diuretics can cause hyponatremia. Kidney disease just will stop reabsorbing the sodium and it's just going to get wasted. Wow, I don't know why I have all these slides. Sorry, guys. As far as increased or normal extracellular fluid volume, that can cause hyponatremia. You can actually drink so much water that it causes hyponatremia. Not common, but it can dilute that sodium down. Edema causes hyponatremia because of the shifting of the fluid. Edema due to heart failure, liver failure, or kidney failure are going to cause us to have low sodium. Excessive hypotonic IV fluids. Remember, when we give too much of that hypotonic solution, it can cause hyponatremia because of the shifting that occurs. And then let's look at our older population, our older adults. What can happen as you age that causes hyponatremia, right? We've already talked about medication. We see lots and lots of different medications that they utilize. All right, so let's flip over and talk about hypernatremia. Remind me again, what is hypernatremia? Too much sodium. So water deprivation, meaning we are NPO, we're not taking anything by mouth. Sodium becomes too concentrated. So NPO requires that hypotonic solution, either half normal saline or a third normal saline. When we think about heat stroke, that's losing water at a very, very fast pace. So then the sodium goes up. Excessive sodium intake. There are some statistics in the US, about 70% of adults live in a state of hypernatremia. Why is that? We eat lots of processed food, fast food, TV dinners, things like that, that have lots and lots of sodium in them. Excessive sodium retention. So why do we retain sodium? Endocrine disorders, kidney disorders, that's going to tell our bodies to hold on to that sodium. Fluid losses, sweating, breathing, burns cause hypernatremia. Again, that's a problem in our older population because, one, they're not drinking too much, they're not drinking enough. So their sodium gets retained, right? They have more trouble making food. So what do they go do? They eat the processed foods or the fast foods. Tastes in our older adults also change, and so we see them add more salt. I'm sure if you go and think about your grandma and grandpa, right? They always salt their food before they even try tasting it. So let's shift into hypokalemia. Hypokalemia, what does that mean? It means low potassium. So what causes shifting in my potassium to be too low? Do you see the similarities that caused my sodium to shift? Also can cause my potassium to shift. So abnormal GI losses, vomiting, NG suction, diarrhea, inappropriate laxative use can cause that not only for my sodium to shift, but will also cause my potassium to shift. Renal losses, excessive use of potassium excreting diuretics, skin losses such as diaphoresis, wounds, burns. We can also think about hyperaldosteronemia, which is an endocrine problem. That is that aldosterone that can cause problems. Insufficient potassium intake, inadequate dietary intake, usually that's very rare. IV fluids, if we see one, we'll probably see the other and we'll have deficiencies for both, right? So if we see hyponatremia, we're probably going to also see hyperkalemia. I'm sorry, on that last slide, if we see hyponatremia, we're going to see hypokalemia, not hyper. So now we're going to flip to the other side and we're talking about hyperkalemia. Again, You're going to see a lot of similarities. There are a couple of differences that I want to point out, and that's going to include one of the things that people don't often think about that causes hyperkalemia, again, is that dietary intake. People are told you can't have salt, and they respond by saying, well, I need something, right? I need something to make my food taste good. So they buy salt substitutes. And what are they made of? Pure potassium. So then they see too much potassium because they're overdosing on it when we told them not to have any salt. So diabetics is the other big one that can cause hyperkalemia. Potassium is all about nerve impulses. Sodium is more about muscle irritability. So potassium is all about transmission of those nerves, specifically the heart. So when you hear the word potassium, your brain should automatically go to heart. On the low side, we see heart problems. On the high side, we see heart problems. When it comes to potassium, it doesn't matter which way you go, it's going to cause those heart problems. So if I would ask you a question on the exam that stated potassium is out of range and ask you what your priority was, you would say cardiac. Heart is always the answer when it comes to potassium. So again, I'm not going to read this. Just know that the heart is your priority when you're talking about kalemia. So these are the two labs I want to make sure you memorize for this week. Sodium, 136 to 145. That can vary a little bit depending on your textbook. 135 to 145 is usually what I remember it because it's the fives. And then your potassium, 3.5 to 5. Remembering that sodium is our muscle irritability, right? Potassium is our heart, our cardiac. And that concludes this chapter. If you have any questions, we'll chat about it in class. Thanks, guys.